afternoon, everyone. So we'll talk about CERAB versus Endografts. Where do we stand? I don't have any disclosures that are pertinent to this talk. So I guess this is almost the kind of case that we're looking at right now. What's the best treatment option? I think all of us will agree that balloon angioplasty is probably the wrong thing to do. In this case, there's enough data to look at that. Stenting is a very good option. We all know that stents work really well in large vessels. But there are many options, right? Are you going to do a balloon expandable stent? Are you going to do a covered stent? What kind of configuration of the covered stent? Are you going to use kissing technique? Are you going to use a CERAB technique, which is a covered endovascular reconstruction of the aortic bifurcation? That's what we were just talking about in this case. Or are you just going to go ahead and do open surgery? In this case, obviously, with a very fairly heavily calcified aorta that you can even see on this angiogram, it probably would not be the most suitable option. And this is probably a few years ago. This is what I did. I just did a kissing stent, came out great. And you always have to question, is this a good long-term option? We all know about the task classification. Obviously, we're talking about mostly the C and D lesions where they're fairly heavily calcified, long segment occlusions. The more complex disease is what we're really going to focus on in this talk. One of the challenges in managing complex aortic disease is obviously calcium, right? It's resistant to angioplasty, and there's a lot of recoil, and there's obviously a risk of rupture of the artery, and you always have to keep that in mind when you're treating these vessels. Stenting is an effective treatment or primary therapy for iliac artery disease as per current guidelines, and obviously the Society of Vascular Surgery recommends stent grafts in instances of severe calcification based on all the data that we've had. Obviously, some of the stuff that you guys have already seen, the COBAS trial, I'm not going to go into details. Obviously, the 5-year results showed that covered stents were much better. There were some criticism to the trial. They looked at binary stenosis and not primary patency. There was no separation between common iliac artery stents and external iliac artery stents. There were some self-expanding and balloon expanding stents, and there were a small number of covered stents at 5 years. So, when you start looking at the 5-year data and you only have a few patients that you're looking at, you have to kind of keep that in mind. But I think overall, we all agree that covered stents do really well. So here's one of the articles from 2015. It's the first result of a covered endovascular reconstruction of the aortic bifurcation, treatment for aortoiliac disease. This is essentially what they did. They put a main stent in the aorta, and then in there you basically put in 2 stents, and you almost have like a top cap, and then you have 2 stents that are coming into it, and that configuration is ideally supposed to be the best. The patency rate based on their trial was actually pretty good. Their primary patency rate at about 2 years was between 80 to 90%, which is almost comparable to what we see, if not better, what we see as opposed to covered stents. So primary patency 87% and 82% at 1 year. Now it's hard to compare this. It treated more complex disease, so it's difficult to compare to just kissing stent series. But nevertheless, we think they have similar patencies. When you look at the hemodynamic comparison of the stent graft configurations, I think this is where it kind of shows you that a CERAB technique is the most ideal situation, where you don't have a lot of dead space and there's no radial mismatch, so you don't really lose energy. If you look at the control of velocities on top, the peak systolic velocity and the peak diastolic velocity fairly uniform. And as you start going down the pictures, the bare metal stent, you can see some mixing towards the end. And the covered stents, the kissing covered stents also have a lot of different colors in their graphs. And when you look at CERAB, you can see their systolic velocity is nice and uniform, as in most of these. But when you start looking at the end systolic velocities or the peak diastolic velocities, the CERAB really appears to have the most uniform configuration. So the conclusion from this was that there are distinct locations where flow disturbances occur, and they're related to radial mismatch. A CERAB reconstruction is the most unimpaired physiologic reconstruction. Just an article showing you a couple of pictures showing you what a CERAB technique would potentially look like. This is a patient that I think had kissing iliac stents, and you can see some of the stents are actually crushed. And when you convert these patients into a CERAB technique, you can see the orientation or the pictures actually look much better. There's no mismatch between the two sides. So here's another case, maybe not as similar to this, but a patient has significant aortoiliac disease, and we'll talk about a UK multicentral retrospective trial, and they actually looked at 116 patients who were treated with the CERAB technique. 82% of them were TAS-D lesions. And their patency rates were not that horrible. At about 3 or 4 years, you were looking at about 50-60% primary patency rate for the more complex lesions. And when you look at the assistant primary patency rate, they were between 80 and 90% at about 3 to 4 years. So not that bad. I think an Endologics device, obviously, it's off IFU use is probably the most ideal CERAB technique because you're not really building anything. So physiologically, it really should be the best. Tom Maldonado probably has one of the largest series of treating aeroiliac occlusive disease with an Endologics AFX unibody graft. There were 91 patients, 67 were claudicants, 24 had CLI. There was a fairly low complication rate based on this study. And at all times, assisted primary patency was more than 98%, and secondary patency was close to 100%. So this is at all times. This is looking at their graphs. Most of them were TAS-C or D lesions, majority of them, and their Kaplan-Meier curves are fairly strong. There was another trial actually from Galway, Ireland. They also looked at unibody, and they compared unibody grafts or a CERAB technique versus aortobifemoral bypass for aeroiliac occlusive disease, right? Should we just be doing open bypasses on these patients that have the TAS-C, TAS-D lesion? So it's a retrospective data collection that 20 Endologics cases, 47 aortobifem. And what actually they noticed was there was a statistical difference at 3-year freedom from intervention and amputation-free survival in the sense that the aortobifem patients did better than the Endologics graft. And here's their Kaplan-Meier curves. Again, majority of the cases were the higher TAS classification, so majority of them were TAS-C and D. There were some B. And if you look at the Endologics, the light blue is the Endologics, and you can see as time goes on, there was a little bit of a statistical difference between the two curves. So there's some data out there that maybe we don't know long term, right? We're not sure what works. Whether when you're comparing to an aortobifem, is that better or not? Surgically, we know an aortobifem does really well once you do get them out of the perioperative period. So to conclude, I think covered stents are a feasible option for complex iliac lesions with good long-term outcomes. I think we really need good comparative trials looking at different stent configurations for complex TAS lesions. And that's how we'll be able to understand what the outcomes are, and then we'll be able to provide guidelines as to what the best reconstruction technique should be.
Fantastic.